Yeah. Good evening, everyone. We welcome you all to this ASCO-endorsed CPOM Foundation webinar series. And today's topic is on strategies to prevent relapse and changing paradigm in the management of relapsed diffuse large B-cell lymphoma. A few housekeeping instructions before we begin. Please ensure that the internet connectivity is good to have a seamless experience. By default, all the attendees will be in mute and listen-only mode. Attendees can also choose to ask questions by typing in the Q&A section, and this session will be recorded. A few words about CPOM Foundation. CPOM stands for Creative Portal for Oncology Education and More. It is a not-for-profit organization tasked with educating practicing oncologists and trainees, and a portal for increasing access to patient resources and improving awareness globally. And this particular webinar series, a series of 4 webinars, and this is the second of the 4, and it is endorsed by the American Society of Clinical Oncology. And today's educational grant is by Intas Pharmaceuticals, NATCO, and Sun Pharma. And CPOM was mainly started by Dr. Santosh and myself, and then we have Dr. Rachan Shetty, Dr. Chandrakant, and Dr. Poonam Maurya. All of us are medical oncologists, and we are trustees of this not-for-profit foundation. And the agenda for today goes like this. We have the first talk on strategies to prevent relapse of diffuse large B-cell lymphoma by Dr. Fredrick Hegemeister, and followed by a changing paradigm in the treatment of relapsed DLBCL by Dr. Jason Westin. And we have 2 case presentations by Dr. Santosh and myself, and we have a few concluding remarks and summary by Dr. Santosh. And we have very eminent hematologists who are going to be session chairs today, Dr. Vikram Mathews and Dr. Manali Kamdar. And the planning committee members include myself, Dr. Santosh, Dr. Rachan, Dr. Chandrakant, and Dr. Poonam Maurya. To introduce Dr. Vikram Mathews, Dr. Vikram Mathews is the current director and professor of hematology at Christian Medical College, Vellore in India. He completed his medical school training and internal medicine residency at CMC Vellore, and subsequently he completed his DM in clinical hematology from the same institute. He has also done a postdoctoral fellowship in stem cell biology at the Washington University in St. Louis for 2 years between 2001 and 2003, following which he was a bone marrow transplant fellow for 1 year at the same university. He has over 150 high-impact publications, and he's also authored 5 textbooks. His cost-effective study of using arsenic trioxide in APML has been practice-changing in upfront management of this entity. As a clinical hematologist, he's very well-respected in his field, not only in India, but also worldwide. And his areas of interest include myeloid malignancies and allogenic stem cell transplantation. And he has received many international awards for his contributions to his specialty. And we also have Dr. Manali Kamdar, who will be the other session chair, and she completed her medical school training in Mumbai, and subsequently she underwent residency training in internal medicine at the East Carolina University in North Carolina, and she chose to stay at the same university for a hematology and oncology fellowship, and she also served as a chief fellow over there. And subsequently, she completed another fellowship in blood and marrow transplantation at the Stanford University. And in November 2014, she joined the Division of Hematology at the University of Colorado and is currently the Clinical Director of Lymphoma Services at University of Colorado. And she's a clinical researcher in malignant hematology with a focus on lymphomas, autologous stem cell transplantation, and also CAR-T. She conducts clinical trials with novel agents or chemotherapy with the hope of improving outcomes in the field of lymphoproliferative malignancies. Now I request Dr. Vikram Mathews to introduce the first speaker, Dr. Fredrick Hegemeister. Over to you, Dr. Mathews.
Thank you so much, Vishwanath. I really want to say on behalf of everybody here, thanks to CPOM for organizing these training sessions. They're very useful for us in India to get perspective from international speakers. Even before I start the introduction, I want to especially thank Dr. Fredrick Hegemeister and Dr. Jason Westin for taking the time off to do this for us. It means a lot for all the speakers over here. Very grateful for your time and effort in this educational program. I think for most people on this talk, for sure, Dr. Fredrick Hegemeister does not need much introduction. He is very familiar to all of us, those of us in the hemato-oncology space, especially with lymphomas and Hodgkin's lymphoma and aggressive lymphomas. But we just go through the motion in terms of his earlier education, at least. He did his undergraduate in Stanford, a degree in UT Southwestern Medical School, a residency at Charity Hospital in Louisiana, a fellowship in cancer medicine at MD Anderson, and then continued to stay on there since 1979. As all of us know, his key areas of interest are Hodgkin's lymphoma and aggressive lymphomas. Numerous publications which have had major impact on the way we manage these conditions, significant impact on the outcomes of these conditions. He is very passionate about his work, as you will soon hear from his talk, because I've heard him many times. And he's always striving to push the threshold and increase the bar in terms of clinical outcomes. He's a recipient of numerous awards. I'm not going to go through all of them. And he's on the editorial board of a number of journals, very actively involved in academics. Over to you, Dr. Fredrick Hegemeister, for your talk. Looking forward to it. Thank you.
Thank you. Thank you so much, Dr. Vikram. We have a lot of things to cover today, and I would like to jump right in to this. My assignment was to discuss the identification of patients who might relapse and prognostic factors primarily, but I'm also going to talk about some of the newer therapies that have been proposed for management of some of these lymphomas. The first slide that I'm showing you here is only about the different kinds of large cell lymphomas that we have had to deal with. All of these were called large cell lymphoma at one time.
Dr. Fredrick, my apologies. Can you go to slideshow board? You're right now on the...
Oh, I'm sorry. Okay. So many of these were all large cell lymphomas at one time. However, the blue ones that I've outlined in blue, we've identified as being different lymphomas in particular. Primary CNS requires different types of therapy. We're not sure about large B-cell lymphoma, although in primary mediastinal, but we know that it is a different type of lymphoma as opposed to the garden variety diffuse large B-cell lymphoma, NOS. And high-grade large B-cell lymphoma with MYC and BCL2 rearrangements also require special attention, with different types of therapy being proposed for that particular disorder. So the first thing I want to go into is different identification of patients who might be at high risk. And that includes, first of all, GCB and non-GCB subsets. These came from the Mayo Clinic, where they were identified by the Hans algorithm, which I don't have to go into for this particular group. However, GCB did better as far as progression-free survival and overall survival. It's interesting that the double hits are mostly in the GCB subgroup, but there is a group of non-GCB who do very badly, as well as a group that does somewhat better. But they're all lumped together in this particular analysis, because this was before molecular subtyping was being accomplished. I do want to talk about the IPI, molecular subtypes, and initial PET as being factors prior to the start of therapy that might indicate outcomes. In this study, which was an older trial that was completed over many, many years, that was promoted before rituximab was even invented, and then rituximab was eventually added to the study. 370 patients were treated with CHOP without rituximab, and the PRs and CRs were randomized to go through stem cell transplant or no transplant. This progression-free survival number at 2 years looks different, but it's not statistically different as far as the failure-free survival curves are concerned. However, for high-risk patients, there was a significant difference. That is to say, patients who had an age-adjusted IPI of 3. The overall survival was also affected by doing a stem cell transplant. So some people might say, if you happen to have 3 adverse features, all 3 adverse features, then you need to seriously think about doing a stem cell transplant if all you're doing is giving R-CHOP chemotherapy. That was suggested at the time, and no one has refuted that since. However, this was not accepted by many people, and therefore it did not really become a standard of care. In addition, the dose-adjusted EPOCH-R versus R-CHOP trial had also mixed results. There were too few diffuse large cell lymphomas that were considered double hit or primary mediastinal enrolled in this study to conclude that PFS with R-CHOP was equivalent to dose-adjusted EPOCH-R, which was a regimen that had been suggested to be better for those two groups. What's interesting is that the idea that double expressors did not do well in the original database that was looked at by Johnson is also true in this particular study. And it really didn't matter whether you got dose-adjusted EPOCH-R or R-CHOP. The results with double expressor lymphomas was much worse than it was for those who were not double expressors. So I think that's interesting. It just tells us that we really don't know what double expressors are for the most part. If you look at the lower right-hand side, you can see that only patients with IPI of 3 to 5 were considered as a subgroup in the supplemental data in this particular manuscript, and there was a significant difference with a p-value of 0.0411 between those patients who received dose-adjusted EPOCH-R versus R-CHOP. That's the blue line was the ER versus RC, which is R-CHOP, which is the yellow line. So those patients who have high-risk disease would therefore include those who have an IPI of 3 to 5, and perhaps those patients really should receive EPOCH-R or investigational therapy as opposed to R-CHOP. This was just, there have been so many variations on the IPI. I'm showing you one of the most recent ones, which is also points out the fact that beta-2 microglobulin has been looked at a number of different times over the years for the last 30 years or so at least, trying to figure out whether it's an adverse prognostic factor and how to include it in an IPI. But this was just using laboratory tests, including the hemoglobin, the LDH, and you can see that the beta-2 microglobulin in a validated cohort that was used to evaluate this particular group of patients, those patients with a very high beta-2 microglobulin did the worst as far as event-free survival was concerned. And we do believe that beta-2 microglobulin needs to be included in any kind of IPI or PI system that's used to identify high-risk patients. Unfortunately, it hasn't gained traction, mostly because older studies did not include beta-2 microglobulin as a part of routine blood draws. The other thing that's really interesting is that in this particular study of 79 genes and 574 cases done through the German Hodgkin study group, or large cell lymphoma study group, they chose genes that were represented at least 10% of the population. They could only genetically classify 47% of these cases. And 4 groups were identified. The Notch 1, which is the N1 down here on the left-hand side over here, as well as the MCD group. And I'm mentioning this in particular. This is overall survival for all of those that were classified. And these are 2 subsets, molecular subsets of ABC types. You can see down here that their outcomes are really poor compared to other ABCs and the BN2 group. The overall survival for GCB subtypes were actually quite good compared to, which is what we might expect. But notice that some of these other ABCs are not as bad as these very bad risk groups of patients. And I'm bringing that up because I'm going to talk about MCD again in a couple of other slides. This is a plot that shows what happens to these particular cases and whether they are bad or good kind of outcomes. And the MCD, it represents a larger number of patients with ABC subtype of large cell lymphoma. So the other thing that's important is, of course, double hit, which we know is an important prognostic factor, but this has been looked at with TP53 abnormalities as well, and was published in 2021, looking at patients who had both TP53 abnormalities and were also double hit. They had really poor overall survivals compared to the rest of the patients. And here is progression-free survival is exactly the same. So it might be that it might be that TP53 is really very important. And if they happen to, if it happens to be abnormal, but double hit negative, it's not so bad. So the double hit remains important, but if it happens to be TP53 abnormal, then they really have a bad outcome. It also suggests that some patients who are TP53 negative and have double hit positive, who are also in this group, that those double hits are not so bad. In fact, they don't do any worse than those patients who don't have double hit positivity, as long as P53 is negative. It's very interesting, and I think we need to consider that when we look at double hit cases. This is a retrospective analysis of 2,000 cases from 8 centers in the UK, looking at FISH for BCL6, 2, and MYC. This is the overall survival for those who had single hit MYC. This is for those who had MYC and BCL6 rearrangements, who were 3A positive. And it turns out that this translocation of 3A positivity for BCL6 is a very important outcome factor and shows you that the overall survival is worse for those particular patients. However, if you look at this, those who are negative, it's not clear at all why these patients did so much worse. So these patients have a different means for expressing MYC or for having worse outcomes than do those who are 3A positive. They still are worse than single risk MYC. There was no analysis yet in this particular presentation from Lugano where they looked at BCL2, that is to say BCL2 MYC rearrangements compared to this particular subgroup. I want to mention MTV as well as metabolic heterogeneity. This is yet to be analyzed and repeated in a number of other studies. But if the original PET shows molecular heterogeneity, that is to say, it's not homogeneous in its uptake in large masses, then patients have a worse outcome. This is the result of PFS for those who have a high MTV and high molecular heterogeneity. And these are for the other two groups, those who have low MTV with any molecular heterogeneity. And this is high MTV with a low molecular heterogeneity. So this molecular heterogeneity may play an important role in the management of patients. So far, I'm going to show you more data that will show you that metabolic tumor volume, or TMTV, is also a very important prognostic factor. This is a series of patients who were looked at, reported by Kostakoglu, and she looked at total metabolic tumor volume, dividing it into quartiles, and found that it was a very significant indicator of overall survival to have a high metabolic tumor volume, even more important, than cell of origin, which was also important, as was the IPI. But this had a much more significant p-value, suggesting that perhaps total metabolic tumor volume is really the thing to look for. As far as during therapy, we all recognize that diagnosis to treatment interval is a very important outcome for patients and telling us whether patients are going to do well. If patients have very bad disease, they get treated more quickly. And it's really an indicator of how bad the disease is. If they are treated within 13 days in this particular study, they have very bad risk disease and a high chance of failing therapy, of having a failure of therapy. But what's really also totally interesting about this particular set is these are the number of patients, or percent of patients, who fail to achieve EFS 24, that is getting to 2 years of follow-up without having progression of disease. You can see here that some patients were out as long as 80 days without starting therapy, and were patients who had a low risk of developing disease progression by 24 months. That's kind of interesting to me. And this curve that drops off shows you that the longer that the patient can be followed without therapy, it actually indicates that they will do well. This is part of the reason why some of the big randomized studies that have been done to analyze new data or new treatments for patients hasn't worked because they're all good risk patients as opposed to bad risk patients. And we do need to make an effort to enroll patients on trials who have high risk disease as opposed to low risk disease. So diagnosis, treatment, and interval remained important. This is also within 12 months versus having more than 12 months from progression-free survival. And this is from the start of second-line therapy. And you can see that this makes a big difference if you progress within 12 months as opposed to waiting at least 12 months to start on therapy. So this idea of having bad risk disease that can be identified only after you start therapy may or may not be true. It's just a choice of management. If the patient can wait to be treated, they will generally have better outcomes. This was also a study that looked at primary refractoriness in the Goya trial. And this is patients, this is overall survival. These are patients who were primary refractory, that is to say, developed disease on progression. And these are patients who had no primary event at all. And this green one is no POD12 event, that is progression within 12 months. If they had one within 12 months, this was their outcome. So the patients who were primary refractory were very similar in outcome to those patients as far as overall survival compared to those patients who had progression within 12 months. This is also the SCHOLAR-1 study, which I think is going to also be important for Dr. Westin's talk. It's a multi-retrospective study of 2 prospective and 2 observational studies, 636 patients with refractory large cell lymphoma. This definition of refractoriness is very important to remember when referring to this particular study. If they relapse within 12 months from stem cell transplant, they were refractory to initial therapy, that is, developed progressive disease while on therapy, or were refractory to second-line therapy. They were included in this analysis. This is the event-free survival for those patients who actually entered CR before going on to getting a transplant. And however, the CR rate was only 3%. So this only represents 3% of the patients who were actually in this particular analysis. So don't bet that you're going to be able to take patients like this and then get them into CR and go for transplant. It's not going to happen very easily. It can happen, but it's rare. Notice that PRs fall off just as if those who don't even respond to therapy. This is the value of early response also by PET scan outcome. Looking at PET2 or PET4 negativity, it's important for those who have low IPI, low intermediate IPI, intermediate high IPI, or high-risk disease. These are those who are negative at 2 and 4 cycles. These are who are still positive. And you'll notice that for all different IPI subgroups, the PET scan was an important outcome. I will also say that the way the response was a little bit different than we normally think of, but nonetheless, it indicated that you can use the PET scan to indicate outcomes regardless of IPI. This was a very interesting study also, I thought, and to me, kind of changed our treatment patterns for patients who have early stage disease. It's 128 patients who were actually received 3 cycles of R-CHOP. 4 fell off the study and although they were enrolled, they were not treated. There was no disease greater than 10 centimeters in this study. 114 of these patients, that is 89%, became PET Deauville score 1 to 3 early on. Out of 14 patients who were PET positive, received radiotherapy and ibrutinib, that's intravenous radiation. For those who have been alive long enough to know what that particular therapy is, it's fallen off the market. No one uses it. Those who were PET negative received only 1 more cycle of R-CHOP, so therefore 4 cycles of R-CHOP, and no radiation therapy was administered. The progression-free survival and overall survival for this entire population was extraordinary. Only 3 out of these 114 patients had disease progression. Deaths to non-Hodgkin lymphomas causes was quite low, and to non-Hodgkin lymphoma was much, much higher. almost 3 times higher for this progression-free survival and overall survival curves, which include all patients who are on the study. This is outcome by Deauville PET score. Just, I want to point out that of this particular analysis, this is Deauville PET score of primary mediastinal large B-cell lymphoma, and those with the Deauville score of 1 to 3 are here, and those with a 4 are here. 74% of those who are Deauville score 4 received radiotherapy, but Deauville score 5 is a disaster. So that's very important for this particular study, but also important is here that these patients did not receive radiotherapy. This is in the rituximab era. 5-year overall survival results look very similar. So the Deauville score may not be so bad. So this is a non-inferiority study that was reported at Lugano just this last few weeks ago, looking at Deauville score 1 to 3 after having had immunochemotherapy. All of them received anthracycline as well, of course, and these are patients who are in complete metabolic response after the end of therapy. So it's progression-free survival is on the left and overall survival is on the right, and this is, of course, radiation versus no radiotherapy. So I'm a complete believer in the fact that you don't need to do radiation therapy in those patients who have this supposedly bad risk disease, as long as their PET scan becomes a Deauville score of 1 to 3. It's a non-inferiority study, but they stopped the study early on because they realized that there were such few events that they would need at least 3,000 patients, more than 3,000 patients, in order to show that this data was not inferior. Of course, the red line is those patients who receive radiotherapy, and the blue line is observation, but those curves are right on top of one another, and so are the overall survivals. This to me, although there have so many other studies that have been done with ctDNA, I thought that this one was one of the ones that really stuck in my mind, and it's the first time that I saw that it was really impressive. These are people who at the very beginning had a higher ctDNA level than those who had a lower ctDNA, and this line is just drawn across here as a way to tell us which groups would do better or not, depending upon how they did ultimately. And those who had a complete response are the green bars, and you can see that the green bars are more than the yellow bars, which is only partial response, or stable disease, which is all over here. There's a couple of stable over here too, but this is highly significant as far as overall response is concerned. And it was also significant as far as EFS was concerned. This was the results for patients who had low ctDNA levels versus high ctDNA levels before starting therapy, who were untreated. And this is the result for those patients who had relapsed disease. I was fairly convinced by looking at this, and I thought we need to evaluate this more and make some sense out of it and try to figure out how we can incorporate this into all of our treatment algorithms in some way. So this is other various pretreatment features also correlate with ctDNA. It correlates with stage, with IPI, low versus high, and total metabolic tumor volume, but not cell of origin. And you can see that cell of origin is right over here, makes no difference. But as you go from a low IPI to a high IPI, the amount of ctDNA goes up. It also goes up according to stage, and this is also total metabolic tumor volume. There is a better event-free survival actually for ctDNA than for DTI. So although both of these were important in multivariable analysis, ctDNA was more important than diagnosis to treatment intervals. So you can kind of figure out maybe who those are who are going to progress by looking at the amount of ctDNA that they have, and that will tell you whether their diagnosis, whether they will be able to wait or whether they have to start on some investigational therapy. And I think we're going to have to work that into our treatment algorithms. This is MRD assessment after the patients have had therapy. This was from ASH last year. These are samples from 5 centers that were evaluated by a different method than the others that I have shown you, 119 samples, and 97% of these were genotypes. So we're getting better at being able to figure this out about how to figure these out. And if you look, this is after cycle 2, day 1. This is after cycle 3 or day 1 on cycle 4. And the amount of ctDNA determined very early on whether patients were going to stay free of disease and progression free at the end of therapy. This is the ctDNA. So I think this analysis, which looked at ctDNA at different levels, tells us that as we give more therapy and the patient remains free of disease by ctDNA, we're going to be able to tell that these patients have a high likelihood of being cured. That will replace PET scans. So this is progression-free survival by PET, and this is by MRD data. This was also presented recently at Lugano. Notice that they do correlate one with the other, and that MRD positivity and PET positivity sort of correlate with one another. Negativity even more, with negative PET and negative MRD sort of correlating. But it looks like these PFS are much wider than are these PFS levels. Overall survival, of course, affected by MRD. In addition, this also stratifies using PET, using ctDNA, also stratifies patients with PET negativity. These are patients who are PET CR at the end of therapy, and they were stratified according to whether they had ctDNA that was not detected versus detected at the end of therapy. And this is PFS. So I hope I have convinced you that ctDNA at the beginning and at the end of therapy are both important at determining whether patients need to be treated with a different type of therapy or whether they are going to progress and die earlier. The standard of care therapies have included an attempt to improve treatment with lenalidomide. Unfortunately, in a large multi-center prospective study of 570 patients, including ABC subtype only, there was no difference in progression-free survival or overall survival. The dose was only 15 milligrams every 14 days. And notice that the median DTI was 31 days. These are both good risk groups of patients. So it's going to be very difficult for lenalidomide in any way or any other investigational agent to show any benefit by either for PFS or overall survival, because they are all generally good risk patients by DTI. In addition, patients, I thought this was an interesting study back that was at ASH 2021. I have not seen the publication. Using a simplified comprehensive geriatric assessment, these patients were determined to be frail, and all they received was R-squared. This was the progression-free survival for these people, and being over 80 automatically made you frail in this particular study. So I think this is an option for some patients, and whether they could receive ibrutinib along with it is another question as well, or some other drug like that, another BTK inhibitor, say pirtobrutinib eventually. Venetoclax also was added to a dose-adjusted EPOCH-R for double hits. And unfortunately, this is the curve for those patients who receive venetoclax plus dose-adjusted EPOCH-R as progression-free survival. And here is their survival. More people died because of venetoclax and dose-adjusted EPOCH-R with infections. And so venetoclax should probably no longer be attempted as a treatment of patients with large cell lymphoma, especially in combination with dose-adjusted EPOCH-R. It has been used to try to treat Richter syndrome. I mentioned the MCD group and the N1 group. This is also from Wyndon Wilson, who is also pushing this whole idea that this group of patients, when they are treated with ibrutinib plus R-CHOP, did better than those patients who received placebo versus R-CHOP. They couldn't really demonstrate there was some difference in event-free survival here in the younger patients and the ABC groups, but the real difference was in this MCD group and the N1 subgroups, suggesting that these patients should perhaps be treated with a BTK inhibitor plus R-CHOP. This was POLA, R-CHIP versus R-CHOP for untreated large cell lymphoma. Everyone is aware of this particular study, and whether you want to use POLA or not is entirely still a matter of debate between clinicians in the United States. I think it's gaining some traction. However, if you are a lumper, you believe in this, but you might say overall survival, who cares? We don't want to give POLA because the overall survival is the same if you're a lumper. I'm a splitter, and I think there are some patients in here who probably will do better when they receive the POLA R-CHP as opposed to POLA R-CHOP or just R-CHOP. I don't know who those are yet. This was an attempt with using ctDNA, however, in the POLARIX trial, and looking at progression-free survival from cycle 2, day 1 in the POLAR R-CHP treated patients. And this is looking at the log fold change of greater than 2.5 versus less than 2.5. So if you don't have a big log fold change in your outcome early on, this is the progression-free survival that you end up with, and this is the overall survival that you end up with. So the same is true in patients who are treated with R-CHOP, but not shown on this particular slide. So I think that's important, and it's something that we still might look at in all investigational trials. This is an acalabrutinib-based trial that is ongoing. If patients receive acalabrutinib, and then if they have a less than 25% reduction, they go on to combination therapy. And if they have a greater than 25% reduction, they are continued on acalabrutinib plus dose-adjusted EBOCAR or R-CHOP for standard of care treatment. This includes high-grade large B-cell lymphomas, unclassified GCBs, and ABC types. This is the kind of responses that have been seen already. This was at ASH 2021 before they showed any of these results that I showed you just before. ABCs did better, which you might expect because this is a BTK inhibitor after all. This is an interesting trial as well, which includes acalabrutinib plus R-CHOP for large cell lymphoma, and it's ABC, GCB, and molecular high-grade large B-cell lymphomas and unclassified. They're randomized in favor of arm B. If it fails to obtain profiling, then they just get 5 cycles of R-CHOP. I'm sorry. And if they are randomized to get R-CHOP versus R-CHP and R-CHOP and acalabrutinib. That's an ongoing study. This is a very complicated trial, but what it is trying to do is taking that MCD group alone. This is a small number of patients. I don't know how they're ever going to enroll all number of patients into this study. However, it's a SAC trial, so it's being done in Europe. And they may be able to accomplish it. And patients receive on a randomized basis either R-CHOP or acalabrutinib plus R-CHOP and then continue on that therapy regardless. But they are then stratified in 4 groups, depending upon whether their PET is 1 to 3, a PET 4, which is considered intermediate, and a PET 5, versus MRD negativity or positivity along the way. It's a complicated study, and I don't know how we're going to ever make any sense out of it or how the investigators are going to figure out what to tell us. This was our Smart Start trial, which was headed by Dr. Westin, where patients received RLI for 6 weeks, and those patients who had a good response or didn't continued to receive the same therapy plus CHOP or EPOCH-R. So our rituximab, lenalidomide, and ibrutinib at reduced doses for a total of 6 cycles of therapy. About 35 or 40% of patients who received RLI alone at this point were PET negative. It was supposed to only be for ABC types. What we found out is that these results, progression-free survival, is actually incredible. This is quite high, nothing that we quite expected. And there is a patient even here, one of mine, who only received 6 weeks of just the immunotherapy, never took the chemotherapy because he refused treatment. And he is now 5 years into this particular analysis, still free of disease. I saw him 2 days ago. He still is in complete remission, and the overall survivals were also extraordinary. I'm going to show you what our current study is. It's called the Smart Stop trial. Patients receive what's called little u, doesn't stand for anything, but it's easy to say ultra. So they receive 4 cycles of that therapy, followed by the same treatment and versus 2 cycles of CHOP. If they've had a CR by PET, they're monitored by ctDNA. If we're looking at projected a complete response rate after ultra of at least 75%, which is going to be very challenging and interesting. Ultra is lenalidomide, tafasitamab, rituximab, and acalabrutinib. I think it's an interesting study, and I can't wait to see what the outcome of this might ultimately be. Notice that in the cohort 2, patients who are PET-CT negative receive only ultra. They never receive chemotherapy. This is BV-Nivo, a similar trial that we are doing. BV-Nivo with our chip, and then followed by those people who are CRs will receive further therapy, but notice they only receive 4 doses of our chip, whether they are CRs or PRs, because we've added BV-Nivo. And this is our early results that were just presented at Lugano. Epcoritamab has been added as frontline therapy to R-CHOP. And in this presentation from Lugano, double hits and triple hits did as well as all of the patients who were in this particular trial. The results are only at 9 months of follow-up, but that's pretty interesting. And I'm not so sure that epcoritamab plus chemotherapy is not better than what we think our CHOP will be. Of course, a randomized study to that versus POLA, our chip, is in progress. How that will ultimately turn out is not clear, but I think this stands a very good chance. The addition of bispecifics to initial therapy is going to play a big role in management of the patients. Notice that the overall response rate in this particular study was 100%. And the CR rates between 80 and 85%, depending upon which groups you look at. Glofitamab plus R-CHOP is very, very similar. This is with the patients who had low, intermediate risk, high, or high risk disease. The IPI doesn't matter anymore. Doesn't matter anymore as far as response is concerned. And mosunetuzumab may or may not be better. Notice that the response rate of mosunetuzumab plus CHOP, known as M-CHOP without rituximab for untreated large cell lymphoma. The response rates are shown here with an overall response rate that's very respectable in the first-line treated patients, as well as complete response. I have not seen follow-up of this particular data with progression-free survivals or overall survivals as yet. Finally, this is ZUMA-12, taking people who have an inadequate response to initial therapy. I have to say that it may be questioned by some people as to whether these patients really had bad disease. They all had bad disease. They were either refractory, developing progression while on treatment, or they had persistent disease after the end of treatment, or they progressed if we could not do a biopsy, and they progressed with either observation or even when they got ZUMA-12. So these were very, very bad risk patients. The response to ZUMA-12, the overall response rate was 85% and the CR rate 74%, which is really impressive. And the median duration of response, progression-free survival, and overall survival was not reached a median follow-up of 9.5 months. So that's the worst group you can have, leading to this study, which Dr. Westin will probably mention, but doesn't have in his slide set, fortunately. I'm going to show this. So it's axi-cel versus standard of care therapy, a bold move. However, it's something that is being done and headed again by Dr. Westin. He presented just this outline as an abstract at Lugano very recently. So I thank you for your attention to this presentation, and I'm happy to discuss it or when we get into the cases or talk about different specific issues. Thank you.
Thank you so much, Dr. Fredrick Hegemeister. I will hand it over to Vishwanath. Are we taking questions now or towards the end?
So we are running short of time. Can we take questions during the case discussion?
Yeah. Okay, over to you then.
Thank you so much, sir. Now we move on to the next session. I request Dr. Manali Kamdar to introduce Dr. Jason Westin.
So good evening, everyone. This is off to a great start, and I am so delighted to introduce my dear colleague and really very honored to introduce Dr. Westin. So Dr. Westin completed his medical school training at the University of Florida, Gainesville, and then subsequently completed residency at the University of North Carolina, Chapel Hill, and a fellowship in hematology and oncology at MD Anderson. Jason Westin is currently the director of the Lymphoma Clinical Research Program, as well as the section chief of Aggressive Lymphoma Research Team at MD Anderson. He's the chair of several committees at the ASCO and also the director of Lymphoma Treatment Planning Committee. His research interests primarily focus on designing and conducting innovative clinical trials, as we saw the SMART START trial and the SMART STOP trial. Dr. Westin has published extensively in various high prolific journals like New England Journal of Medicine, the Journal of Clinical Oncology, Lancet Oncology, Nature Medicine, to say the least. He has presented his research at multiple national as well as international conferences, including ASCO and ASH. He has received multiple awards to fund his research, including a prestigious Conquer Cancer Foundation Leadership Development Program Award and a Career Development Award from the American Society of Clinical Oncology. With that, I give the floor away back to Dr. Westin for his excellent talk.
Thank you so much, Dr. Kamdar. I appreciate the kind introduction, and I would like to thank the organizers of the meeting for allowing me to join this wonderful seminar today and to share my talk. I will move quickly through because I know we want to make sure we leave time for the cases at the end. But today I'm going to talk to us about the changing paradigm in the treatment of relapsed large B-cell lymphoma. These are my disclosures. So I'll start off with a slightly controversial lead-in, calling the paradigm we had the prior paradigm. And today we're talking about a shift of a paradigm or a move into a new era for how we manage refractory or early relapse large B-cell lymphoma. But the prior paradigm, as I'm phrasing it, is the stem cell transplant paradigm. Many of you are very familiar with this clinical trial published in the New England Journal of Medicine nearly 30 years ago, showing that in patients with chemosensitive relapsed aggressive lymphoma, transplantation was superior to more chemotherapy. So on this trial, everybody had already received DAP chemotherapy and responded, and then were randomized 1-to-1 to receive further DAP chemotherapy versus auto transplant. Clearly, this was an improvement in survival. This launched the era of stem cell transplant as the de facto standard for patients with relapsed disease. There's no Rituxan in this trial. This was not limited to large cell lymphoma. A lot of the diseases, including this, would not be considered aggressive lymphomas today. However, this was accepted whole cloth and was the de facto standard of care. And this led to what I call the prior algorithm. This was published by Dr. Jonathan Fredrick more than a decade ago in an ASH review paper, which became kind of the background slide that everybody used as the prior algorithm. In this algorithm, as Dr. Hegemeister mentioned in his expert talk, most patients are cured with frontline therapy. And for this, we use a round number of 2/3 are cured. But of those who are not cured with frontline therapy, 100 patients, only half would be eligible for transplant due to age or comorbidities. Only half of those would respond to treatment, and ultimately about 10% of patients with relapsed or refractory large B-cell lymphoma could expect to be cured. Not a great standard of care, but this was the best we had from around 1995 up until just recently. So I'll show you the new data, but this is the background of where we were. Of course, it wasn't a complete desert with no attempts to improve. Many attempts were done to try and improve outcomes in second line, including the famous CORAL trial, published now more than 10 years ago in the Journal of Clinical Oncology. The CORAL trial randomized patients to receive either RDAP or RICE, and then to receive autologous transplant in those who responded to this. And what we saw in the trial was there was really no difference in outcomes for either chemotherapy group. They were equally good or equally bad, depending upon if you're a glass half full or glass half empty kind of person. But I think the most depressing part of this trial, the most depressing figure, in my opinion, in large B-cell lymphoma literature up until this recent change, was this figure, which looked at patients who had relapsed within 1 year and had received rituximab with their initial treatment. So that lower line, the yellow or brown curve that drops dramatically, those are patients with early relapse and prior Rituxan. In my practice, this is like 75% of patients who relapse with large B-cell lymphoma do so within the first year, and nearly everyone has prior Rituxan. So despite intensive chemotherapy, 100% of patients have real side effects with RICE or DAP. Only about 25% of patients could expect to be event-free at 1 year. So treating 4 patients to benefit 1, not really a great situation. So CAR T-cell therapy is something that we've all heard of. It's a true breakthrough in the sense of in the greatest sense of the word. And we've recently seen Dr. Nilapu, our colleague from MD Anderson, publish in Blood with the other ZUMA-1 investigators the 5-year follow-up from the ZUMA-1 trial. We know that in aggressive and refractory lymphomas, plateaus of survival curves generally mean cure. And I think we can now definitively state that CAR T cells cure patients. And this curve showing that the 5-year disease-specific survival settling out around 50% shows that CAR T cells are a juggernaut that is here to stay. For those that are not as familiar with CAR T cells, this is what the CAR T cell construct looks like. These are 3 different CAR T cells that have a lot of similarities. And effectively, these are the 3 that have been approved in the US and used extensively in clinical trials around the world. The lysocell product on the left side, axicell in the middle, and tisagenlecleucel on your right-hand side. They all have the same CD19 binding domain, so the CD19 antibody of FMC63, and then they have various co-stimulatory domains, with axicell using CD28, lysocell and tisagenlecleucel using 4-1BB. And we know that 4-1BB and CD28 have different kinetics in terms of their expansion and different T cells that might expand. So effectively, you get a faster and more rapid off ramp for CD28 versus 4-1B is more of a slower expansion and more durable persistence, perhaps. So these 3 products were studied in patients with third-line relapse refractory disease and shown to be quite effective and therefore have been approved. We'll talk about where they go next, but just as a quick cartoon, which I like visuals, I think this is sometimes helpful. The way you make a CAR T cell is taking a patient's own T cells via apheresis, using the viral vector shown to insert DNA. This causes expression of the chimeric antigen receptor, the CAR molecule on the surface, which then is reinfused into the patient. These CAR T cells rapidly grow and expand up many times 1,000-fold from the infused cells to the actual number of cells at peak expansion. These CAR T cells can now see the wolf in sheep's clothing, the tumor cell that's hiding in plain sight, usually with CD19 as the target. This causes CAR T cells as well as non-CAR T cells to be recruited to the tumor microenvironment because of the inflammatory milieu and have an antigen creep and effectively have a synergistic immune explosion. I have this slide and I kept this one. I like this, even though this is an older slide now. Are CAR T cells worthy of the hype? The answer is, of course, yes, they are. But Dr. Hegemeister showed the SCHOLAR-1 trial. This is one that Dr. Nilapu and I participated in, where we looked at patients with primary refractory relapsing after autologous transplant or refractory to second-line treatments of chemo. So prior to CAR T cell, what were the options we had versus the 5-year overall survival for ZUMA-1, showing that there is a clear difference in outcomes of chemo in third line versus CAR T cell in third line. And that, of course, raises the question of what if we didn't save these therapies for third line? What if we tried to move CAR T cells up to earlier line of therapy? That would be something clearly a logical question to ask. This is from a review paper that Dr. Laurie Sen and I published in Blood last year. I'm not going to go through all of this, but basically this is, at the time we published this, the most recent update from these initial studies. There is a typo in this figure that I corrected in the manuscript, but I haven't corrected on the slide. This is the Transcend study, not the Transform study. But nonetheless, it showed that the similarities between the CAR T cell products were great, and the similarities between axicell and lysocell in terms of response rates and CR rates were quite high. Tisagenlecleucel was slightly lower in terms of its efficacy on this clinical trial, and we'll see that showed as well in the second-line studies. So the hypothesis is, if we go back to the prior paradigm algorithm, having transplant helping or being available to maybe half the patients, of that half responding and 10% ultimately being cured, could we improve upon a cure fraction that's that low by using a CAR T cell therapy? And this question was asked in, of course, 3 randomized phase 3 trials: the ZUMA-7 trial, the Belinda trial, and the Transform trial. ZUMA-7 was originally published last year in the New England Journal, and then we recently published an update this summer based upon overall survival, and I'll show you the newest data for the overall survival and the newest data cut that we just presented. For those that are not familiar with the ZUMA-7 study, here is the schema. It took 359 patients who were adults and who had large B-cell lymphoma that either was refractory to first-line therapy, defined as not achieving a complete response, or that had progression of lymphoma within the first 12 months. So basically refractory or early relapse large B-cell, randomized 1-to-1 to axi-cel versus standard of care. Standard of care was platinum-based chemotherapy, followed in responding patients by autologous transplant. And for patients who didn't respond on either arm, they could come off to receive subsequent therapy, which on the standard of care arm could include third-line CAR T-cell, which was available in the countries where the trial was conducted as a third-line option. The updated data I'm going to show you focuses mainly on the key secondary endpoint of overall survival, which is quite important. The baseline characteristics were well balanced between the treatment arms and showed that patients had 3/4 of patients had primary refractory disease, and nearly 30% of patients were over age 65. So not an easy to treat group with intensive therapies. And the consort diagram shows that even though the trial was randomized 1-to-1 and it was stratified to make sure that the arms looked fairly similar, that more than 3 times or approximately 3 times as many patients received definitive therapy with the axi-cel treatment arm versus standard of care. 94% received axi-cel versus only 36 who could achieve high-dose therapy and autologous transplant. And the reason for not receiving high-dose therapy and autologous transplant was largely due to lack of response to chemotherapy. We already saw that in the CORAL trial. The event-free survival was generally quite poor, around 25%. That's what was seen in the ZUMA-7 trial, where chemotherapy doesn't work that well in patients who are refractory to chemotherapy. But importantly for the overall survival analysis, 57% of patients on the standard of care arm came off of protocol and received subsequent cellular immunotherapy, which is nearly all CD19 autologous CAR T-cell therapy. So more patients received CAR T-cell in third line than received transplant in second line on the ZUMA-7 standard of care arm. And here's the take-home slide from ZUMA-7 overall survival, is that it improved overall survival, statistically significant with a hazard ratio of 0.73 and a one-sided p-value of 0.0168. The median follow-up is mature, 47.2 months. And so I think that we can say that this curve's, the separation is not a obvious you could drive a truck through it, but it is statistically significant. And there is a clear separation early, which is durable throughout the entire follow-up for overall survival with stability of the curve. So I think we can say that axi-cel is curing more people than standard of care in the second line. The median was not reached for axi-cel versus 31 months for standard of care. And if we look at 4 years, 54.6% versus 46%, which of course is wonderful, regardless of what patients received as a third line therapy, to have more people cured in second line. But it perhaps even more impressive when we consider that more than half of the patients on that lower curve effectively crossed over by receiving a third plus line cellular immunotherapy. So that was the prior paradigm of try chemo first, save CAR T-cell for later. And it shows that that prior approach of chemo first, CAR T-cell if it doesn't work, is inferior to second line axi-cel therapy. So we call this a paradigm shift. We think that this is a true breakthrough, and overall survival is one of the hard endpoints that are really difficult to argue with it as something that is not meaningful. The hazard ratio of 0.726 equates, if we do the math, to a reduction in the risk of death by 27.4%. And we concluded both in the talk at ASCO as well as in the New England Journal that this is curative therapy. There's no reason to beat around the bush and talk about potential and maybe it could be. CAR T cells cure people. We call transplant a curative therapy. We've called it that way for nearly 30 years. There's no reason that we should be too clever and not give the same title to CAR T cells. So that is a term that is now applicable to CAR T cells as a curative therapy. This is the first trial in nearly 30 years to significantly improve overall survival in the second line curative setting. So a true breakthrough in the sense of how we manage our patients. The algorithm that I showed you at the beginning, we'll come back to this at the end of the CAR T cell section, but at the ASCO meeting, we proposed the algorithm Dr. Sen and I published last year should be considered as a new algorithm, replacing the one from Dr. Friedberg from more than a decade ago, where at that time we'd ask the question about, is a patient eligible for transplant, yes or no? Now we ask the question, how long ago was first-line therapy? And in the 75% or so of patients who are relapse or refractory within the first year, we ask the question, is this patient eligible for CAR T-cell therapy? And we think those numbers will be greater than we saw for the 50-50 split for transplant. Axi-cell improving overall survival in second line over the prior standard of care makes the case that the left-hand side of the curve, CAR T-cell, is the preferred approach. So the Belinda trial, shifting gears to talk about tisdalin-lacleucel for just a moment, was also published in the New England Journal of Medicine last year. This trial had a more complicated design than ZUMA-7. Patients were randomized 1-to-1 to tisdalin-lacleucel or standard of care. That was very similar. However, the manufacturing timeframe for tisdalin-lacleucel was much longer, about 6 weeks all told. And so most patients received bridging therapy, sometimes more than one cycle, sometimes more than one type of bridging therapy. So effectively, this was almost third-line CAR T-cell therapy on this trial because of the long manufacturing time and the heavy use of bridging therapy. Patients who had progressive disease after bridging therapy did very poorly, and that may have had a big influence on this trial. The other part was that this trial did allow for crossover, but patients had to receive a first type of platinum-based chemotherapy, not respond, receive a second type of platinum chemotherapy while the tisdalin-lacleucel was being manufactured. And if they still had progressive disease and were still fit, then they could then cross over to receive tisdalin-lacleucel. So kind of a weird design there of having to have two lines of chemotherapy. So crossover was almost fourth line therapy on this trial. The time to infusion, as mentioned, was very long, and I mean very long. Outside of the US, it was 57 days from randomization to infusion of the CAR T-cell product. In the US, it was 41 days. This is way longer than what we see for the other products, which are usually in the 20 to 30-day range and may have had a major impact in this disappointing curve, which basically showed that tisdalin-lacleucel and standard of care had no difference whatsoever, contrasted with what I showed you from the Axi-cell, where the event-free survival was superior and overall survival was superior. Here, there's zero daylight. We don't need a p-value to see that there was no benefit for tisdalin-lacleucel compared with standard of care. The third study, which was published initially by our chair of this session, Dr. Kamdar, and updated earlier this year by Dr. Kamdar and Dr. Abramson and other co-authors, published in Blood, was the Transform study looking at lisocabtagene maraleucel versus standard of care. The design of this trial is very similar to the other studies in that patients are randomized 1-to-1 to receive liso-cel or standard of care. Here, patients could receive one cycle of bridging chemotherapy and could cross over if they did not achieve a good response on the standard of care arm. The delivery of liso-cel was very high. The ability for patients who were randomized to liso-cel to receive the product 97% versus only 47% of patients who were randomized to standard of care were able to get high-dose therapy and autologous transplant. So the same we saw from ZUMA-7 is there was a big discrepancy in patients who received definitive therapy due in large part to lack of response to chemotherapy. Patients had a poor risk phenotype, including, didn't have a box here, but including 3/4 of patients, nearly 75% of patients who were refractory to initial therapy, which is a very high risk patient group. And here is the updated results for the primary endpoint of event-free survival, showing an enormous difference favoring liso-cel, with liso-cel having a significant improvement, both clinically and statistically improvement in event-free survival versus standard of care. What I'd comment is that the curves look, in my eye, fairly similar between the ZUMA-7 trial and the Transform trial for the standard of care arm, meaning that we can sort of use that as a cross comparison, saying standard of care in this early relapse or refractory patient population really doesn't do well at all. And the majority of patients don't receive significant benefit, similar to what we saw in the CORAL trial, effectively validating these studies as high-risk patient populations. And therefore, the impressive results of the CAR T-cell are even, I think, more impressive because of the high-risk group. Liso-cel having a huge improvement in event-free survival, which was seen across all key subgroups. There was no group that benefited more from chemotherapy. And then here's the update on the overall survival published earlier this year in Blood, showing an improvement for liso-cel, where there's a clear separation that starts early and is durable throughout the follow-up period. It's not statistically significant, but I do think there is a clear separation here, showing that liso-cel looks to be a great option over standard of care. Again, the number of people who received a liso-cel on the standard of care arm was a high percentage because of the lack of durable benefit from chemo, which of course can inflate the overall survival in a standard of care arm. Adverse events are lower for liso-cel, so cytokine release syndrome is generally lower than it is for Zuma-7. I didn't have the slide in the interest of time, but CRS for axi-cel is closer to 90% for all comers versus much lower for liso-cel. For neurologic toxicities, that's more common with axi-cel than liso-cel. So I would conclude the implications of these second-line studies basically show that for patients with earlier relapse refractory disease, axi-cel and liso-cel are superior to therapy and transplant, the old paradigm, shifting to the new paradigm. There is an overall survival benefit for axi-cel and a strong trend for liso-cel. Unanswered questions are patients that relapse beyond 12 months. We don't know what to do with those patients. We don't have any data to suggest that transplant or CAR T-cell would be better. And then for patients who start chemotherapy and have the clinical benefit, it's unclear if transplant versus CAR T-cell would be a better option. In my practice, if a patient comes to see me having already had a clinical benefit for RICE or DAP, I would continue down the path of transplant and not cross over if they were having a nice clinical response already. I'd say we still have an unmet need. 4-year overall survival of around 55% is better than what we'd seen for prior treatments. Still means that nearly half of patients need a better option. So back to the algorithm, the prior algorithm versus the new one, we talked about how time from therapy is the way we look at this. Are patients eligible for CAR T-cell if they relapse within 1 year? And we think that we will cure more patients than what we did with the prior paradigm. Beyond 1 year, it's reasonable to still consider transplant for patients as they'll be more likely sensitive to chemotherapy. And then we will briefly touch on some of these newer approaches. I want to make sure we have enough time for the cases and for discussion. So I'm going to go very quickly through this next section. Beyond CAR T-cell therapy, we heard about polatuzumab from Dr. Hegemeister. Tafasitamab is an antibody usually combined with lenalidomide that targets CD19 and has shown some promise in patients with non-refractory relapsed large B-cell lymphoma. Loncastuximab tesirine is an antibody drug conjugate targeting CD19, also showing some promise in third-line settings. And then bispecific antibodies versus CD20 and CD3. This is a rapidly emerging class that Dr. Hegemeister touched on briefly. I'm going to briefly show you data on 3 of the leading products here, because I think this is an area that's extremely exciting and we'll be hearing more about over the coming years. Bispecifics are a concept that are likely familiar to this audience, but it's effectively taking the binding domain from an antibody that targets a T cell, CD3, and a binding domain from an antibody that targets a B cell, and in this case, CD20 is the target. And these are being fused together. So effectively, the left hand and the right hand of the bispecific antibody are grabbing onto different cells, a T cell and a B cell, and bringing them into close proximity. And this is a cartoon showing the schema of some of the lead compounds thus far. Mosunetuzumab, glofitamab, odronextamab, epcoritamab, and plamotamab all have a lot of similarities. There are some differences in how the designs are put together. These are not the same antibodies, but effectively the binding domains are going after the same target. Epcoritamab was just recently approved in the US. It's dosed subcutaneously. It's dosed with a ramp up during the first 3 cycles of a weekly dose, then every other week for cycles 4 through 9. And then beyond that, it's every month. Treatment until progression or unacceptable toxicity. And that's potentially a problem for this drug, is that treatment until progression, if you are potentially curing people or giving a long-term benefit, that's a long time until the patient opts to stop therapy. So this is a very impressive drug, but it is a drug that potentially is given for quite a long time. Here's the overall response rate of 63%, a complete response rate of nearly 40% in a highly relapsed refractory population, showing that overall the median progression-free survival of 4 months. However, for patients with complete response, see that looks pretty awesome of having a durable response. Across all key groups, the CR rate and PR rate look pretty similar, including patients that had prior CAR T-cell. So potentially a great option as a third line for a patient who either had a CAR and didn't work or cannot get a CAR for various reasons. The subcutaneous dosing, as well as the step-up dosing, starting at a very low dose and then giving a higher dose, basically helps mitigate the risk of cytokine release syndrome, which is seen most commonly on the first full dose on day 15. The second antibody to talk about is glofitamab. This is an IV therapy given fixed duration. So epcoritamab was subcutaneous for indefinite, glofitamab is IV for a fixed duration. Also has a step-up dose with a pre-treatment of obinutuzumab, and then a step-up dose on day 15. First full dose is cycle 2, day 1. Patients receive 12 cycles and then stop. And the duration of response for patients that have had a complete response or any response, to me, looks very impressive. The responses are seen across all groups, including those with prior CAR T-cell, which I think is quite impressive. And in patients who were refractory to previous therapies, the CR rate was around 1 out of 3. But for those that were relapsed, not refractory, it was 70%, quite impressive. For patients who have a complete response and stop treatment, this is a complicated slide, but it was published in the New England Journal of Medicine, so I could refer you to that paper. But effectively, it shows that patients who have a complete response, stop treatment, generally keep their response. However, if they progress, they could be retreated with the same antibody, and several patients went back into a complete response. Cytokine release syndrome, again, seen in the first few doses, and then it effectively disappears once you get past the first 2 cycles. The last drug to talk about is mosunetuzumab. This is a drug approved in the United States for follicular lymphoma patients. The single agent response rate for large cell or aggressive lymphomas was lower, 42% with a CR rate of 23%, different from the other 2 I showed you, which were in the 60% and 40% range. But when it's combined with polatuzumab, the drug Dr. Hegemeister mentioned in the POLARIX trial, the response rates now in this doublet are very good, 65% and around a 40% CR rate, including in patients with prior CAR T-cell. The side effects appear to be lower with Mosun, lower overall side effects, as well as lower cytokine release syndrome. And there's a study comparing this versus R-GEMOX, Mosun Pola versus R-GEMOX, the so-called SUNMO trial. So comparing the bispecific antibodies, they have step-up dosing for all of them except for Mosun. Glofitamab and Mosun have fixed duration versus epcoritamab, and one I didn't have time to talk about, odronextamab, both have indefinite dosing, and the CR rates in heavily pretreated patients are, in my opinion, very impressive, nearly 40% across most of these trials of a complete response rate. So in conclusion, the paradigm has shifted. CAR T cells are curing more people than manufacture. Bispecific antibodies show great promise and are off the shelf. However, they're expensive, logistically difficult, and have a long duration of therapy. I would offer to our audience that Dr. Hegemeister and I would love to collaborate on research with you, and would encourage you to consider applying for our lymphoma fellowship. Dr. Vishwanath was one of our star fellows in the past, and we're glad to continue to have a good relationship going forward. But we have a fellowship program at MD Anderson that allows talented and smart people, both internationally as well within the US, to come spend a year of time for us with research. And with that, I would conclude, and thank you for your attention.
Thank you so much, Dr. Westin.
Now we move on to the next brainstorming session. This will be about the case discussion. And for today evening's case discussion, we have wonderful, amazing, eminent experts from the field. We have already listened to them. So we invite Dr. Fredrick Hegemeister, sir, Dr. Jason Westin, sir, Dr. Vikram Mathews, sir, and Dr. Manali Kamdar. So we have some 2 wonderful cases for presentation. So the first case will be by Dr. Vishwanath S. Again, he doesn't need any introduction, but yes, it's an honor to introduce him. Ever enthusiastic, and he's a senior consultant and professor in medical oncology department at Apollo Hospitals, Bangalore, and also the director of the DNB academic program. And he's trained at premier centers, including the MD Cancer Center fellowship in lymphoma. So over to you, Dr. Vishwanath, for the first case presentation.
Yeah, thank you so much, Dr. Poonam. And after those wonderful talks from Dr. Hegemeister and Dr. Westin, we'll run through these cases with our experts today. Um, so this is the case. So this is a 56-year-old female, known hypertensive, was initially treated in Thailand. She presented with left shoulder pain for 1 month and left axillary lymph node swelling of 1 month duration. And she was also found to have a left supraclavicular lymph node. I'll come to the PET scan, and extensional biopsy was done, which showed CD20 positive, CD79A positive, CD10 negative, BCL2 positive, BCL6 negative, MUM1 positive, and Ki67 of 60%. And it was reported as a high-grade B-cell lymphoma, non-Hodgkin lymphoma, so DLBCL of a non-germinal center subtype, and the stage was 2A, and the RIPA was 1/5. She just had the LDH, which was elevated. She had 6 cycles of R-CHOP and she had a complete metabolic response. So this was the initial PET. So multiple lymph nodes in the supradiaphragmatic region. And then after 3 cycles, she had a complete metabolic response, and she continued to have a CMR at the end of treatment with 6 cycles of R-CHOP. And unfortunately, after approximately 9 months of completing the treatment, in March 2021, the PET-CT she presented with the skin nodule over the left arm, and PET-CT showed metabolically active enlarged bilateral axillary lymph nodes, as you can see here, and the large one on the right side, which was 3.1 times 2.4 centimeter with a high SUV of 12.3. And she also had a metabolically active cutaneous thickening in the left arm, and which was just 5 millimeter, but the SUV was 4.6, and a focal uptake in the right breast, which was probably considered as non-significant according to the radiologists. So the biopsy of the left arm nodule so was suggestive of DLBCL relapse. It was CD20 positive, but this time it was CD10 positive. Previously, it was negative. The BCL2 and c-MYC were positive. In fact, BCL2 was diffusely positive, and c-MYC was positive in 40% of the cells. And BCL6 was weakly positive in 20% of cells. Ki67 remained at 60%. And a FISH was done, which was only showing MYC rearrangement in 30% of cells, but negative for the BCL2 and BCL6 translocation. At this time, the diagnosis of high-grade large B-cell lymphoma, but this time it was CD10 positive, so it became a GCB. It was a GCB subtype. That's how it was reported. My first question would be to Dr. Manali Kamdar. So this patient is 56-year-old, good performance status, and she relapsed within 1 year of complete response. So what are your thoughts on this patient?
So as Dr. Westin so brilliantly walked us through the entire data set, I think previously we would assess patient based on transplant eligibility, salvage eligibility, but I think now we would actually look at the timing since initial response and the timing to relapse. Clearly, this is a high-risk patient because of the relapse happening within a year of complete response. The patient is not primary refractory, which made up for about 75% of all the 3 data sets. It's an early relapse patient, which is a 25% of most of these pivotal 3 randomized studies that Dr. Westin looked at. So I do believe that the overall prognosis with conventional chemotherapy is fairly poor for primary refractory. When you look at the CORAL data set, of course, these are patients who all relapse within a year. If they have received Rituxan, like the way this patient has had, the complete response rate and the EFS is exceedingly poor. So I think in countries where CAR T-cell therapy is approved, the plan would be to pursue CAR T-cell therapy. And a lot of factors would come into play. I assume she is definitely CAR eligible. She's a young female patient. The bigger question is, are we able to collect her and then wait until CAR manufacturing happens? Or do we have to give her bridging therapy? We do know that bridging therapy, at least based on the TRANSFORM study, didn't have a lot of impact on outcome. So I think in countries where CAR is available, looks like the patient's tumor burden may be well, for now, I would potentially collect her and then assess the need for bridging treatment. I tried to hold off on initiating bridging prior to apheresis just to maintain the T cell health and the quality of the CAR. I think in countries where CAR is not available, I think it's a bigger issue. I do feel that primary refractory patients are way worse than early relapses. So I think in those patients, I would go ahead and start off with salvage chemotherapy. RICE, RDHAP, GEMOX, totally, your calling. And if the patient does elicit a response and CAR is not available, again, I think an auto transplant may be reasonable. Clearly underscoring and making sure that the patient is aware that the responses are not going to be the 40% cure. So I think that would be my plan.
Perfect. So, and the overall prognosis in these patients, there's actually a scoring system which actually predicts the 2-year survival from progression. And based on the SEAL consortium, they found that the two most important factors were actually age and time to relapse. And according to that, the predicted 2-year survival from progression was considered as 41%. And I think this has all been discussed. And this patient, like Dr. Manali mentioned, we did discuss about CAR-T, but in fact, the patient was more keen about going for some salvage therapy. And then patient received 3 cycles of salvage chemotherapy with RICE, and then the PET scan showed complete metabolic response. So, Dr. Westin, you did mention about this, right? So my question is about the significance of PET response, and if the patients have a complete response, would you still go for CAR-T at this stage, or would you consider it for later?
I think for a patient who's had a complete response to chemo, it's difficult to make a case that they should not get more chemo. They're clearly benefiting from chemotherapy, and we know that the problem with transplant is not the transplant doesn't work. Of course it works. It's the getting to transplant, which is the difficult part. So this person's already crossed the difficult stretch of, do you respond to second-line chemo or not? Already has a complete response. And so if this person has a complete response, I would favor going forward with autologous transplant and saving CAR T-cell as a backup if the disease were to relapse. We don't have any data here. None of the third-line or second-line trials have asked this question of what to do in a patient who's had a complete response to chemo. That's a related but not answered question in these trials. So I think that in the absence of a randomized trial showing CAR T or transplant is better, stay the course with the original plan. In a patient who's had a complete response, go ahead to autologous transplant.
Perfect. And I also wanted to point out one thing, that patients who had a CR prior to doing transplant, and then if you look at the Scholar-1 analysis, they actually did much better compared to patients who had residual disease or did not respond to chemotherapy, like Dr. Westin mentioned. So I think this has been discussed, and this has also been discussed. And Dr. Jason Westin also showed us about the lyso-cell as well as the axi-cell in the second-line setting. So Dr. Vikram Mathews, in our research for a country like India, resource limited, I would say, does classifying into GCB or non-GCB in the relapsed DLBCL influence treatment options?
At this time, really, no is my answer. I don't think it really changes anything that we have to offer. Frankly, CAR T-cell is not available for most of us. We have a clinical trial going on at our center, but this would not even come into a factor in our decision of whether to go for the CAR T or not. But as much as exciting as the data that was presented today, we would not be able to offer on our trial the CAR T as upfront for relapse. It will be only post and autologous relapse as part of the inclusion criteria, because it's a phase 1, phase 2 study. But I can tell you the patients that we have done with lymphoma, it's actually quite dramatic. Even a post autologous relapse patient, I could actually show you some pictures. Really bulk disease, day 28 PET, as the first evaluation. Disease is complete. I mean, again, it's all n equals 1, 2, so I don't want to comment too much. I mean, the data is there for the large study data is over there. But frankly, this does not change any of my algorithms at this point in time. There is all the data of adding these other drugs and agents, which for the most part is not available to us.
Perfect. Now, this patient went on to receive high-dose chemotherapy with the BEAM protocol plus autologous stem cell transplant, just like the other experts also agreed, and subsequently put on lenalidomide maintenance. And unfortunately, after 1.5 years, 1 year and 3 months to be precise, she came back with a lump in the right breast, and that proved to be again a large B-cell lymphoma relapse, again a double expressor, and it was and it was unclassifiable by Hans algorithm. So since CD10 was negative, BCL6 was negative, and MUM1 was also negative. So patient is exposed to 2 lines of therapy. What are the treatment options, Dr. Hegemeister?
Okay, so obviously we would probably offer that patient a CAR T. At this point, it would be considered standard of care in the United States. We don't do bridging for patients, or don't believe that they need bridging. But the problem is going to be two that I think of. The first is that we know that patients who have double expressors do badly, or at least a certain subset do very badly. And I'm not sure. I think when they got CAR Ts, there weren't quite enough double hits and double expressors to be able to say whether they did or did not do worse. But there's a lot to think that you could give for people who have non-GCB. If they're non-GCB, they could get treated with RLI, which is ibrutinib plus lenalidomide and rituximab. This patient has certainly received rituximab, but hasn't had those 2 other drugs. And that's what I would think would be something to offer a patient, especially that patient who is not eligible for a stem cell transplant or is older, because in GWAS data, 41% of those patients went into complete remission. And that's a great combination for that particular group of patients if they don't have primary refractory disease. The other thing that worries me is that this patient has some sort of breast disease and likely soft tissue involvement, which is one of my things that I look at and think about the risk of developing CNS involvement. So I sort of think about getting MRIs early on in that kind of patient just as a baseline, and think about that individual patient, about what their risk is for going on to therapy. I certainly would want to do for CAR T cell therapy, and I don't think this is, I don't like bendamustine. The tafasitamab is not going to be a very good choice, I don't think, to take things for a long period of time, although it's okay. And selinexor is another issue. I don't know about further therapy with those patients getting bispecifics may do very well with this kind of therapy, but I think CAR T addresses not only the risk of CNS relapse, but also should be something that's chosen for this particular patient.
Thank you. So we discussed all the possible options of polatuzumab plus BR, but in case the patient has to go for CAR T, it's lymphotoxic, so Benda might be an issue, tafasitamab plus lenalidomide, selinexor. But finally, we went for the next salvage therapy as per the patient's discussion about the finances, so logistics. So we gave 3 cycles of RDAP, and these are the different response rates with the different newer drugs, which we have discussed. And also a point to say that, these drugs are not available in India, and it costs the mammoth 32 lakh rupees to kind of import 32 tablets of 20 milligrams of selinexor. That's $37,000. And polatuzumab is 12.5 lakh rupees for 140 milligrams vial. That is around $14,500. And tafasitamab is also equally expensive, because it's $2,100 for just 200 milligrams vial. So none of these drugs are available, but we've also discussed the data for all the CAR Ts, and Dr. Westin did show that almost like 50% of them have the long-term cure, and probably we're able to cure those patients in at least this subset of patients. This patient, my question is to Dr. Jason Westin. This patient actually has been contemplating CAR T, and they've been trying putting all possible efforts. In fact, I reached out to Dr. Neelapu as well. Has weak expression of CD19 and strong expression of CD20 on IHC. Is she still a candidate for the axicapta gene?
Yes. So CD19, although we know that's the target, there's no mandatory minimum amount that needs to be expressed. We think that really any expression of CD19 should be sufficient for the CAR T-cell product to be able to find the tumor. As you're showing here, there's not a lot of data saying that CD19 correlates, expression correlates dramatically with response. There may be some differences, and that negative confidence interval that you're showing here on the screen shows quite a wide range. But in general, patients that have a low expression of CD19 still can have a very good response, especially compared to the other options that were shown on the screen that Dr. Hegemeister mentioned might have a lot of toxicities and not a lot of long-term benefit for somebody who's now in their third line of therapy. I think if CAR T-cell were financially or logistically available to this patient, I would still proceed with that, even with the lower expression of CD19.
Thank you. Thank you so much. So this patient went on to receive 3 cycles of DHAP and then had complete metabolic response, and also had high-dose methotrexate as CNS prophylaxis, just like Dr. Hegemeister mentioned, and currently is on ibrutinib and rituximab. So I think this has been discussed. So last points, comments from Dr. Vikram Mathews about the role of CNS prophylaxis in this situation.
Yeah, to be honest with you, in this relapse situation, usually there's a CNS IPA at diagnosis to decide on the CNS prophylaxis. In the relapse situation, I'll be honest, I'm not very sure what the real definition of what the indication is. But with breast involvement, we know that from breast to the Barrett's plexus, there's a movement to the CNS. The risk is higher for other tumors as well. So I kind of defer this question to the people who more handle lymphomas all the time, Dr. Fredrick, Hegemeister, and Westin, and maybe Dr. Manali as well. I'm to be honest with you, I'm not 100% sure. I would probably not focus on the CNS prophylaxis so much as just achieving remission and taking for whatever therapy is possible.
I agree with Dr. Mathews, because I think you have the patient on ibrutinib as well. So if the patient has a non-GC phenotype at relapse at this point, ibrutinib will have some BBB penetration, and I probably wouldn't concentrate on the CNS prophylaxis part.
Yeah, thank you so much. And this was the wonderful ASH educational article by Dr. Christopher Flowers, looking at relapsed DLBCL and the various triggers of goal for goals of care discussion. I think this is something which we can read offline. Thank you so much. I would like to thank all the experts for this wonderful interactive session. Now we move on to the next case. I request Dr. Santosh Devdas to present his case. Dr. Santosh Devdas is a senior medical oncologist at MS Ramaiah Medical College, and he's also the assistant professor there and the chief of stem cell transplantation. Dr. Santosh.
Thank you, Dr. Vishwanath. In the next 5 to 10 minutes, we would like to discuss a high-risk DLBCL patient who is in a complete remission after initial treatment of ways to prevent a relapse in this patient. This is a 61-year-old diabetic patient who presented with urinary hesitancy and hematuria, who was PS2 on clinical examination, had a generalized lymphadenopathy and an enlarged prostate. The PSA was normal, and a MRI of the prostate gland revealed a huge prostate with enhancement. Biopsy showed a high-grade DLBCL, which was CD20 positive, BCL2 positive, BCL6 weak positive, CD10 negative, and a MEM1 positive, and a CMYC positive status. The PET scan revealed extensive suprainfradiaphragmatic disease with involvement of the adrenals and a soft tissue involvement of the falciform ligament and the involvement of the prostate along with the marrow deposits. CSF analysis was done at baseline to demonstrate negative status. FISH for translocation was negative, and a final diagnosis of DLBCL non-GCB subtype stage 4 double expressor was made. The IPO was poor risk and a CNS IPO of high risk. He received a cyclophosphamide prephase and steroids, which required hemodialysis for the TLS management, followed by R-CHOP and intrathecal methotrexate for 4 cycles. At the end of 4 cycles, a PET scan revealed a persistent dual score of 4 in a few of the lymph nodes and marrow deposit. these are the images representing improvement, but presence of a residual disease at the end of 4 cycles. He completed 2 more cycles of R-CHOP with intrathecal methotrexate. The last one was as recent as 12th of July. So diving directly into the discussion. So we have this 62-year-old male gentleman who has a high-grade lymphoma with a high tumor volume. And as when lymphomas present to us, we always hope for a cure. But in the back of our mind, we definitely know that this patient is bound to relapse. And as Dr. Westin showed, once they relapse, hardly about 10 to 20% survive with the availability of auto transplant in the absence of a CAR T-cell therapy. So the first question I would ask Dr. Manali, there is a lot of data regarding risk stratification of patients. What do you often use in your day-to-day practice? Do you use RIPI or do you use the NCCN IPA, which people say are is a more robust way of risk stratification in DLBCLs?
Dr. Santosh, Dr. Manali had to leave for the clinic. So Dr.
Right.
Westin, take this question.
Right, Dr.
Yeah,
Westin.
Be happy to take this one. I think they're both great. I think fairly though, the differences in the RIPI and the NCCN IPI do have a little bit better predictive power for the NCCN IPI, but it is a little bit more complicated, and often you're kind of lumping patients into good risk and poor risk. And the revised IPI, the 5-point that we know from our training, the Apples mnemonic of age, LDH, extranodals, and stage, works pretty well. So I think for most patients not on a clinical trial, the revised IPI is generally sufficient and surprisingly still very effective, even in the era of what should be molecular testing and genomics and predictive power based upon this mutation versus that mutation. The RIPI is still a valid tool in my clinic.
Thank you, Dr. Westin. So many times we also get patients with a high intermediate or a low CNS IPI, but they have a breast involvement or an organ involvement which is close to the CNS. Do you always use the CNS IPA or also use other organ involvement like testis, breast, or a paraspinal mass involvement to make CNS prophylaxis decisions? Dr. Hegemeister, we do want to take this question.
Actually, I don't. The CNS IPI is not one of my favorite methods of evaluation. It's not really extremely accurate. I realize that there are some patients who are not considered even, and yet we know that testis is now, we have a standard of care for those patients for testis, and it wasn't one of the features that came out in this particular analysis. So I don't really like the CNS IPI because I think it didn't look at sites that were that should have been included somewhere along the line to try to say something about whether it's useful. Is it useful? Probably, but I don't. And we do use it in clinic to decide who is going to perhaps have a higher risk of developing recurrence. But there are other people who've said that the CNS IPI wasn't useful in their trial or detecting relapse in the CNS in patients at all. So I don't know what the right way to do it is. And I guess the CNS IPI is something to use until we get ctDNA in the CNS, which I think is the right way to probably do it ultimately. The other thing is that therapy for these patients is not adequate. Intrathecal therapy doesn't really do anything except add, I think, to toxicity. Cycling methotrexate in between cycles of chemotherapy doesn't really do anything either except add to toxicity in general practice. Although I think methotrexate probably can be useful in some patients. But the way that we do it probably at Anderson now is just to give therapy with methotrexate after they've completed their going into complete remission in a systemic manner.
Thank you. So you did allude, Dr. Hegemeister, regarding various approaches for improving outcomes. for a country like ours, where we have limited options, though I think we are going to soon get polatuzumab into the Indian market. Would you tailor therapy regimen based on the perceived risk of relapse, somebody like this patient?
So the high risk patients, for sure. I think you asked me. So the high risk patient is probably someone to really think about. And I particularly like, if I think the patient has high risk of relapse in general, I give dose adjusted EPOC, or we would give dose adjusted EPOC. And I think that's all we can really go for right now. I don't think POLA or CHIP I will give to someone who is older, whom I think can't get dose adjusted EPOC. And I'm not convinced about CHOEP for the older patient or even for the younger. So.
Do you even consider a consolidation with auto transplant or a CR1 CAR T cell therapy? Dr. Westin, do you do an auto transplant for anybody in this setting?
No, I don't. So I think that there have been data in the past suggesting that for patients with double hit or other high risk populations, that perhaps an auto transplant in CR1 could be better. Those were randomized. Those were all retrospective looks for double hit. There was one study that looked at this as a randomized trial. However, the benefit size was very small, and you're effectively giving an auto transplant to a significant number of patients who are already cured, which obviously is a lot of toxicity. So I think it depends on what you have as a backup. If the patient does have progressive disease, if you have CAR T cell potentially available as a second line therapy, I would save that and not use that as a first line consolidation. As Dr. Hegemeister mentioned, we are evaluating the potential for CAR T cell as even a first line therapy for very high risk patients on the randomized 23 study, which is up and running globally. But for now, I would not consider that to be a CR1 or even a first line. I would save that for someone who's got proven relapse disease.
Dr. Vikram sir, how do you manage your frail patient with high risk DLBCL who may not even tolerate R-CHOP? Do you have any particular way of dealing with these patients?
Yeah, some of them we just use a combination of rituximab and lenalidomide sometimes, in very frail patients. We really don't have a standard approach, Santosh, to be honest with you. So if somebody is really frail and we don't think he's going to survive chemo at all, our options are really very limited, Sometimes we do things like, we give first cycle RCBP and then see if his general condition improves, cytopenia, if it's all disease related, contributing to the frailty versus due to other comorbidities. But really, it's really physician discretion. We don't have a standard approach.
This is the last question. I would like Dr. Westin to take this. Where do we stand on CNS prophylaxis? This quite a difficult topic with the recent meta-analysis showing absolutely no benefit with the use of either high-dose methotrexate or the intrathecal methotrexate.
Yeah, we could have an entire symposium on just this one question. This is very controversial, and it's a rapidly evolving data set. I think that the answer is we don't know. As Dr. Hegemeister mentioned, intrathecal and intravenous methotrexate have been used and are often used still in people that we presume to have a quote-unquote high risk. But even those people that, based upon the CNS IPI, high risk may be 80% non-real risk. The patients don't have a progression event, even in the supposedly enriched group, meaning that doing a trial of some other therapy, if it's a BTK inhibitor or lenalidomide or something else which may cross the blood-brain barrier, is very difficult if you're treating a large number of patients who don't have true CNS disease, to find those patients that do, and then what your effect size is. So I think the answer is it really is unknown what the current standard of care should be here. And I think based upon a lack of an alternate plan, it is an individualized decision about how much could my patient tolerate if I were to give them IV methotrexate. What is my perception of their risk if it's CNS IPI, or as Dr. Hegemeister mentioned, testicular involvement, spinal involvement, sinus involvement, wherever it is that you think might be a high risk site. I think that there is still value in treating patients with prophylaxis, but I think in some level we're also treating ourselves where we're trying to manage what we know to be a risk, even if therapy may not be that effective.
Thank you. That really gave some clarity for this very difficult question, Dr. Westin. There were a couple of questions in the chat box. Because we are running short of time, I would request the participants to email this question to us, and we will try and get the answers to you as soon as possible from the experts. With this, I will end this webinar, and I would like to thank Dr. Fredrick Hegemeister and Dr. Jason Westin for their wonderful talks. Dr. Vikram Mathews and Dr. Manali Kamdar for being there during the webinar as chairpersons. We thank Dr. Julie Gralo, Mrs. Sarah Backman, and Mrs. Jessica Williams from ASCO, and our colleagues who helped us plan the webinar, Dr. Rachan Shetty, Dr. Poonam Maurya, and Dr. Chandrakant. And I also thank the sponsors, Intas, NADCO, and Sun Pharma for their educational grants. And thank you. The webinar will be available on cpoem.org, which is our website. Thank you one and all for your presence.
Thank you so much. Bye.
Thank you so much.
Thank you. Goodbye.